Good morning to one and all. I'm Dr. Himanshi from SRMS IMS, India. I'm here to present my research on brachial plexopathy in head and neck cancers treated with IMRT technique. So starting with the introduction. Head and neck cancers are most prevailing in the world and they consist of a multi-modality treatment approach, that is surgery, radiotherapy and chemotherapy. IMRT, that is intensity modulated radiotherapy, enhances the therapeutic ratio by increasing the dose that is delivered to the tumor cells while it decreases the dose that is delivered to the normal surrounding tissue. The normal surrounding tissue in head and neck cancers are cochlea, parotid, lips, lens, etc. Brachial plexus is one of the normal tissues which is generally overlooked, which we don't take into consideration while we are contouring the normal structures for head and neck cancers. Hence, brachial plexopathy is a complication which is generally not evaluated at the time of follow-up. So damage to brachial plexus can arise either from surgery or by radiation. It presents clinically as neuropathic pain, sensory loss or motor weakness of the upper extremities. Radiation-induced brachial plexopathy is late toxicity that can present months to years following a course of radiotherapy. So the aims and objectives of my study are to assess the dosimetric parameters of brachial plexus in head and neck cancer patients treated with concurrent chemoradiation by IMRT technique and to clinically correlate those dosimetric parameters with brachial plexus toxicity. So for this study, I included all the patients who came in the Department of Radiation Oncology for head and neck cancer malignancies from November 2019 to April 2021. Patients who were histologically proven squamous cell carcinoma stage 2 to 4A, age more than 18 years, KPS more than 70, normal hemogram, renal function test and liver function test. Normal 2D echo were included in my study. Patients with prior or synchronous malignancies, previously treated with radiotherapy or chemotherapy, stage 4B disease, and patients with comorbid conditions like diabetes, hypertension, thyroid, and signs of peripheral neuropathy on pre-treatment evaluation were excluded from my study. We delineated all the structures GTV, CTV, and PTV as per the RTOG guidelines. Brachial plexus was delineated according to Hall et al. And Domico et al. Guidelines. This is a small video showing the contouring of brachial plexus in the axial section. This is the reconstituted image of the brachial plexus in coronal section as well as the sagittal section. All cranial, caudal, lateral, medial, anterior and posterior borders of brachial plexus were defined. Now, pre-radiotherapy evaluation was done using a baseline MRI scan to evaluate for thickening of nerve roots of brachial plexus and a baseline NCV and EMG testing, which was done under the following headings, that is latency, duration, amplitude, and NCV milli per second. These were the following nerves, that is ulnar, medial, radial, axillary, long thoracic, thoracodorsal, and musculocutaneous nerve, which was evaluated for the testing of brachial plexopathy. Now, after confirming with these tests, when the reports were found to be normal, we went for radiotherapy planning. Dose prescription, no dosimetric constraints were applied for brachial plexus. All patients were planned and delivered a definitive radiotherapy dose of 70 gray in 35 fractions over 7 weeks or an adjuvant dose of 60 to 66 gray in 30 to 33 fractions over 6 weeks, with or without concurrent cisplatin depending upon the indications. So post-treatment follow-up was done after 6 months and 1.5 years of completion of treatment. Clinically, with the help of 18-point questionnaire, neurophysical examination was done and the following nerves that we discussed on the EMG and NCV testing were also clinically tested with the appropriate test. MRI and NCV after 6 months and 1.5 years was done post-treatment depending upon the feasibility. All these scans were also compared with the baseline scan. So now moving over to the results, total number of patients that we recruited for a study were 38. The mean value of Dmax received by the brachial plexus was 65.6 gray, which was much higher than the dose constraint defined by the Imami et al. So among these 38 patients, there were 22 patients, that is around 57% patients who were positive for brachial plexopathy. It was absent in only 16 patients, that is 42% patients. So among these patients who tested positive, the most common symptom that patient came up to the OPD was of the sensory scaling, which includes tingling, numbness, not able to feel, pain, etc. It was followed by proximal arm weakness, and further it was accompanied by pain, stiffness, and activities that impaired the daily life. So sensory scaling was found to be positive in 65.7% of patients, whereas proximal arm weakness was present in 63.1% of patients. Now, this is a clinical assessment comparison of the patient's pre and post RT, where the following tests for proximal arm weakness and impaired hand functions were done and were compared pre and post RT, and we found a very highly significant p value for those, indicating the brachial plexopathy. So as in the photos you can see, this patient has to take a support of his left hand to do the arm above the head maneuver. In this patient, the contour of muscles on both the hands is not normal. One is more bulky than the other. This patient had difficulty in unscrewing the bottle, indicating some impairment in the fine movements of the muscles of hand. This patient had difficulty in shrugging of shoulders, indicating that there is damage to the nerve supplying to the trapezius muscle. Again, this patient had difficulty unscrewing the bottle cap. In this patient, we see that the patient has difficulty in rotating the neck. Now, this is an NCB comparison, pre and post RT patients where following nerves were evaluated under the following headings of latency, duration, amplitude and NCB. So p-value was calculated and the p-value, to our surprise, was found to be highly significant for the following nerves under the following parameters. This also indicates that there is chances of brachial plexopathy, that is radiation induced. We also did an MRI comparison for being very sure of the diagnosis of RIBP, and this was the result where we found that all the parameters were highly significant, indicating that there is brachial plexopathy in the patients, that is radiation induced, which is being overlooked. So this is a summary that clinically this correlates the clinical findings with the MRI and NCB. So there were 20 patients who completed the whole algorithm. Out of these 20 patients who were clinically assessed for brachial plexopathy, after 6 months of the treatment, around 70% patients developed clinical signs of brachial plexus toxicity. And out of those, 50% patients were those whom clinical toxicity was also related with MRI and NCB. There were 2 patients in which the brachial plexopathy was absent clinically, but the MRI and NCB parameters were found to be positive. This indicates that there is some subclinical disease which would manifest later. So now we have a long-term follow-up which includes the median follow-up of around 11 months, where we saw that the 5 patients who came for the long-term follow-up had a progressed brachial plexopathy. All the gradings of the brachial plexopathy as per CTCAE was progressive. So there was no improvement in morbidity due to brachial plexopathy even after 1.5 years of follow-up. Hence, we need to screen the patients for brachial plexopathy. We need not overlook it. So now talking about the discussion, we have various studies which define the dose constraint of the brachial plexus. These are RTOG 0435, 0522, 0412, 0615, 0617, Imami et al. But these studies have been done in breast. So in these studies, the dose tolerance of the brachial plexus was around 60 to 66 gray. Imami et al. Study says is to be less than 60 gray, which was followed in most of the breast cancer contouring guidelines. Brachial plexus dose tolerance in head and neck has a very scarce data. So, but when we saw, what we saw in our study was that the dose received by the brachial plexus was around 65.15 gray, which is much higher than the dose constraint given by the Imami et al. So reason for this increased dose to the brachial plexus in what we found in a study was that the lower neck nodes which were irradiated, that is level 4 and level 5, lymph nodes were irradiated to 66 gray. Therefore, the plexus was receiving high dose and there were high chances of brachial plexopathy. Now, on clinical findings of brachial plexopathy, we have various studies. One is by Kareen et al., which says the commonest symptoms is around for the patient is numbness, then there is tingling sensation and the disease progressed further to the motor weakness. We also found the same thing, that the patients who were coming up at a follow-up of 6 months was having pain, numbness, and it was progressing to the proximal arm weakness when the patients came for a follow-up of around 11 months. Now these are the MRI findings. There are different studies which suggest that there is T2 hypodense, thickening, edema, inflammation, hyperechoic thickening of brachial plexus, perineal fibrosis, and these all suggest the symptoms of brachial plexopathy. So we were surprised to see that around 80% of the patients had similar symptoms. Only perineal fibrosis was one symptom which was not found in any patient. For this to say it could manifest later or a larger sample size might be needed. So now time course to see radiation plexopathy is between 5 to 30 months post radiation. So in our study, most of the symptoms we could see at 6 months only. So when we try to clinically correlate of RIBP with radiological and neurological assessment, we have study by Prakash et al. And on the 2 different dosing schedule, what he saw was that on 2 months follow-up, as per the NCCN follow-up, we followed his patients and saw that there are symptoms of brachial plexus toxicity, which similarly was in our study also. When we followed the patients for around 2 years, we saw that not only clinical symptoms were positive, but the symptoms were also related with the MRI and the NCV findings. So out of 38 patients we recruited, we found the brachial plexus in 70% patients to be damaged after radiation, and this was also confirmed by the MRI and EMG findings. So in rest 18 patients who were only clinically assessed, in which we could not do MRI or NCV due to loss of follow-up due to COVID regions, we found that 8 patients developed positive clinical findings of brachial plexopathy. If we would have gotten a chance to follow these patients, they might have developed the toxicities, and we could have correlated them with MRI and NCV findings also. Now, what can be the suggestions to decrease the incidence of radiation-induced brachial plexopathy? So patients of head and necks are being treated for lower neck. They should be evaluated for early signs and symptoms of brachial plexus. Now lower neck, that is level 4 and level 5. Now here comes the highlight. If while contouring, if we are very particular about the CTV guidelines, then we are very sure that we can, we really have to go to lower neck to treat or not. If we are able to save this lower neck, we'll be avoiding brachial plexus toxicity. So we should only treat lower neck in the patients in which they are actually indicated, rather than treating the whole fields. This will be a game changer in saving the quality of life of patients. So yeah, and second point is, usually patients present with complaints of numbness, tingling, we think it to be cervical spondylitis. Now here we have to stop this and start thinking about RIBPs. We need to screen these patients early. Very sadly, till now we have no definitive treatment for radiation-induced brachial plexopathy. Only symptomatic management is there that we can do by pregabalin or methylcobalamin. Hence, it is very important that on the very initial step, when we are planning for the radiotherapy, we should contour brachial plexus. We should give proper dose constraint. We should try to optimize it during the planning. We should see that the minimum dose is going to the brachial plexus, and we should evaluate the patients further during follow-up for this toxicity also. We should not overlook it. So now finally, to conclude, I would like to say, yes, brachial plexopathy is one of the late complications in head and neck cancer, which is not routinely clinically assessed or detected. There have been cases which have been coming up for follow-up in which there are no signs and symptoms of disease. Only thing bothering the patients are symptoms of brachial plexopathy. Hence, it becomes really important that we evaluate this, we properly screen this, and try to prevent this. So therefore, how to do it? Brachial plexus should be considered as an OAR in the contouring of head and neck cancers. But yes, to finally come to a conclusion, yes, we need more data on head and neck cancer with evaluation of brachial plexopathy, and more longer follow-ups are needed, so we can see to what extent the disease is getting progressed and to what extent we can prevent it. Thank you very much.